Hey guys, welcome back to our monthly AAEM Critical Care Medicine section meeting. And as always, we start with a topic for discussion, sometimes with a case, sometimes with a paper, sometimes with a little bit of both. But today, I don't know that we need a case because we all deal with this pretty often, which is out of hospital cardiac arrest. And while there's lots and lots of debates about the best way to approach cardiac arrest, from mechanical CPR to ECPR, to intubating. One of the things that we all deal with in cardiac arrest, kind of no matter what level, is whether or not to give epinephrine in out of hospital cardiac arrest. And this has been a subject of debate for quite a long time. It's got its basis in animal studies, but kind of repeatedly throughout time, most papers haven't consistently shown a benefit to using epinephrine for out of hospital cardiac arrest, but it remains in the AHA guidelines and is a pretty standard part of our practice. So the paper we're going to talk about today is pretty hot off the presses. It came out in Chest in January of this year. It's epinephrine in out of hospital cardiac arrest, a network meta-analysis and subgroup analysis of shockable and non-shockable rhythms. So this was a network meta-analysis of 18 different studies with almost like 21,600 patients, where they compared epinephrine in a variety of doses, as well as epinephrine with vasopressin against both each other and placebo, as it's a network meta-analysis. So you can do that to see if there was any or what impact it had on the outcomes in cardiac arrest. So essentially, the outcome was no different than what we see in most studies, which is that overall, epinephrine may help you get ROSC, may help you get to the hospital, but it doesn't really help you leave the hospital neurologically intact, which is in line with what I think most of us have seen, both from the literature and anecdotally. Interestingly enough, they did also break down epinephrine in shockable versus non-shockable rhythms in the different studies, and showed that in the non-shockable rhythms, there is some signal that it may help with discharge for patients to be neurologically intact. So to me, that was a pretty interesting finding, and also highlights another small section of this debate, which is there a subset of arrests that we should be using epi in, or should be prioritizing epinephrine in, that we're not currently doing, and maybe not using it in others. So Elias, why don't you kind of kick us off and tell us a little bit about your practice and what you think about this paper?
I mean, for my practice, epi is still pretty standardly used, especially in the CTICU. It is like an inotropic as well as a vasopressor. So it's a very common reach drug, and it's most easily available. And half of the patients already technically on it. Um, so when they do go into arrest, it's a little bit different from the out of hospital arrest, because it's going to be in hospital and predisposed. They're already on some basal level. So the question is usually not so much of reaching for more epi, is more so of what additional support you need. So that's for mine. For my take of it, I think it's still interesting. I mean, it's the only drug that's shown to really benefit ROS for ACLS and resuscitation so far that we know of. Everything else pretty much has been debunked for now, at least from what the recent trials have shown. But what is most important, as David Lend, is the surviving to hospital discharge neurological intact. And currently, we really don't have any really good treatment that would really lend towards that. You can argue ECMO might be a possibility, but that's a different discussion altogether. So yeah, it's kind of limited in what we can have to offer in these kind of patient populations. Although if you don't get them to the hospital and survive surviving, you don't even have a neurological assessment to begin with. So at least that's the first step.
Shadman, what do you guys, as a medical student, you guys are coming up kind of learning about cardiac arrest, and the approach to cardiac arrest and what you guys are doing. So what are you guys being taught in school about epi and cardiac arrest? And is there any kind of discussion in medical school about whether or not this is something we should be doing or giving all comers?
During didactics, it wasn't really that big of a discussion. When we transitioned from being second years to third years, of course, we did ACLS. That's where it got brought up a lot more. But most of the experience I had was outside of school when being in the hospital was being in the ICU. A lot of the doctors were using epinephrine just it just had patients were on a drip and I haven't seen it used. I haven't seen a cardiac arrest yet, so I haven't really experienced it in that situation. But as a drip, I've seen that it can do a lot of good for a patient and try to get them off of other vasopressors.
Elise, what about you guys? Is there any discussion about this kind of controversy in medical school?
Not really much so in like preclinicals. So far, we've just kind of been going off the American Heart Association guidelines and going with that standard 1 milligram epinephrine dose. This was the first time that I started to read more about the high dose epinephrine versus like epi and vasopressors. So
Allie, in your practice, have you made any adjustment either with nurse-led codes or just, they're already on a drip, so you just crank up the drip or change anything for your cardiac arrest algorithm with epi?
I haven't made any major changes. Oftentimes they're not on a drip because I did the surgical critical care training pathway, and in the TCQ, oftentimes, that's not necessarily a patient population who needs inotropic support frequently, and so that's why they're not commonly on epi to begin with. But no, I haven't made any changes. I think I think it's difficult to change or take epi out of the algorithm as long as it's still in the current guidelines and whatnot, to be able to sit there and deviate from standard of care.
Jason and Alex, you guys are in residency right now. When I was a resident not long ago, there became this huge thing where we all kind of got really grumpy about epi and cardiac arrest, and we're like, oh, there's no benefit to epi and cardiac arrest, especially right after paramedic 2. And I had some very opinionated attendings at the time that came out. So there was a lot of discussion. What are you guys teaching your juniors when you have a cardiac arrest, and what are you seeing your attendings do?
So for me, this was a little bit of a deja vu kind of paper because I thought we had a journal club with our EMS folks on the paramedic 2 paper back in October, November, something like that. And so was this study basically a review of all the studies including paramedic 2?
Yeah, so this had paramedic 2 in it.
And so kind of the conversation I remember having with my colleagues at that particular journal club was that I think what people actually cared about when you kind of talk to families is they care about whether or not the brain survives. But a lot of people in our community tend to kind of care more about the heart is beating, and so getting the ROSC is arguably more important. And so unless ACLS guidelines change, I don't think I've seen anything be done different in our emergency department.
Greg, you work upstairs and downstairs.
Mm-hmm.
Yeah. So do you think there is a benefit to getting ROSC, even though we know that these patients probably don't? You see them downstairs, you're like, oh, we got ROSC, everyone high fives, they go upstairs. And from the downstairs perspective, you never see the kind of chaos and downward spiral these patients go on upstairs if they don't end up neurologically intact. So do you think there's any value to that, to getting ROSC?
Yeah, it's it's interesting because I'm dealing with that case right now of someone who is just neurologically devastated after a PA arrest. It's probably not gonna make much of a recovery. It's tough. In the heat of the moment, you have to do what you have to get ROSC. But I also always have the back of my mind niggling this thought of, am I causing more harm? Am I going to create a headache and a problem down the road for a patient? There's an interesting counter argument in all this too, is and it's a little bit of a utilitarian argument that if you get ROSC, but you're neurologically devastated, there's also potential for organ donation here. And that you can't do organ donation in someone who has been dead for a while. So that's not anything that we should think about in the emergency department, but from a societal standpoint, that is an interesting consideration from when we think about what we do for cardiac arrest and why we do it.
Yeah.
The other thing I was going to add was, I think there's this hint in the literature that there is something about VTVF arrest where epinephrine probably is just not very good. And there's these little papers here and there. And I think this sort of adds to this idea that VT and VF arrest is just very different. Giving epinephrine to ventricular dysrhythmia is just clearly going to feed into the arrhythmogenic fire they're going through. And this paper sort of reminded me of the Esmolol papers that came out, the one in 2020 and the one in 2018, that really suggested that maybe there are some patients who are refractory ventricular dysrhythmias who benefit from Esmolol. And maybe this paper kind of adds to this, is that beta agonism is really not good for VT and VF.
Yeah, just as a quick thing, I think to add, the organ donation thing, I think, is an important academic thought, but that's such a difficult topic, and ethically, when you have these patients, either Allie, as the trauma patients, right, or the rest of us who these post-arrest patients, once they kind of start to enter that zone, you really leave the ability, you kind of step away as the physician and let the organ procurement team manage them, so that you're not dealing with that conflict of interest, because your interest is always in that patient and not in how to get organs for other people. So while there's I think an academic thought, I'd be worried if we started thinking about that too much in the setting of arrests, because then we're not putting the priority of our patient, right, which is kind of our oath, at the forefront. Skylar, you always have some nuanced thoughts that are generally beyond me. So what are you doing in cardiac arrest with epinephrine, and has your timing at all changed, and do you use it differently in different types of arrests?
Thanks. Yeah, sorry I'm joining this conversation late. I don't have much to add. I like Greg's point. I do think of this differently in VF and VTAC, and there my priority is defibrillation, not epinephrine. It's antiarrhythmics. It's figuring out if I can get them out of that rhythm however I have to, so I can get them to the cath lab, whatever the case may be. So I do deprioritize epinephrine in those cases. And I think a lot of times they get it just as part of the protocol, but I would not give repetitive doses. And I don't give repetitive doses of epinephrine to VFib, VTAC. If they get 1 or 2 during ACLS, fine, but I'm not giving it every 3 to 5 minutes in those cases, because I agree, I don't think it's beneficial. It doesn't make sense to me. It's an ischemic arrhythmia, and I'm going to make that arrhythmia worse if I continue to give high doses of epi. In PA arrest, we don't really have much else. So I don't think that epinephrine is necessarily harmful in that situation. And I still give epi kind of as usual in run-of-the-mill PA arrest if I don't otherwise have a cause, because I think that's probably the only chance we have at ROSC in most of our PA arrests. But VF and VTAC, I do think of differently.
When you're deprioritizing it in VF and VT, do you say something to the nurses?
Yeah, I usually do. And fortunately, most, I do have some, but I haven't had any recently, VF and VT, that go on for a very long time, but I have had refractory cases. I would say usually in the first couple rounds, they end up getting epinephrine because everything is happening very quickly. Either that's done pre-hospital or as the team is assembling. So I'm okay after the first or second round if they get a dose of epinephrine, but I don't request further doses after the initial couple rounds of CPR.
All right, awesome. Does anyone have any other big thoughts to add?
I think another thing you can consider, other than the utilitarian about organ donation, is sometimes it could be the process for the family as well. So even just getting a ROS for bridging to like a decision making can be kind of meaningful for the kind of grievement process for the family as they're coming to terms with that. So it's something that we're not just treating the patient, sometimes we're treating the patient and their family as well. So that's something to keep in mind as well.
Yeah, it's always very surprising to me when these patients kind of come in with their out of hospital cardiac arrest and you get ROSC and you go talk to the family and they're like, oh, how are they doing? Are they talking yet? And you're like, hey, 5 minutes ago, they were dead and we restarted their heart. And it's a very, they don't realize the severity and the suddenness of this for a lot of arrests. And so giving them that time to get to that place where we can have those more advanced discussions that we have to have upstairs often is really, I think, valuable for them. But it sounds like overall, this paper really didn't change much of anyone's practice and confirmed what a lot of us already knew about using epi or already felt about using epi in cardiac arrest, which is it's what we've got. It probably doesn't work that well, but it's better than anything else. And we should probably think about deprioritizing it. I like that phrasing in VF and VT, but probably nothing's going to change until the American Heart Association kind of gives us the leeway to do that. Awesome. Well, thanks for a really helpful discussion at a lot of different levels. I appreciate it, guys. I'll put in that article and the Sucre tables, which are kind of the foundation of the network analysis, and a nice review of how to evaluate a network and a network meta-analysis with this when it gets posted. Thanks.